Hi there, and welcome to Speaking Frankly with myself, Professor Franklin Joseph. I'm very pleased to have with me today Professor Tom Solomon CBE, who is an eminent figure in the world of infectious diseases. Tom needs no introduction from me, but I'm going to let him tell you a little bit about all the different things that he gets up to. And I'm hoping that myself and Dami Aboyeji, my colleague, will be able to pick his brains today, because that's his specialist area, which is neurology and neurological infections, but take a more wide stance and talk to us about his role as the new director of the Pandemic Institute here in Liverpool. So Tom, tell us a little bit about yourself.
Thank you very much, and thanks for inviting me onto this podcast. It's great to be here. I am the director of the Pandemic Institute, which is based here in Liverpool, but in terms of background, as you said, I'm a clinician. I'm a neurologist, so I see people with brain problems. But my research has always been on brain infections. And early in my career, I spent some time in Vietnam working on emerging brain infections, mosquito-borne viruses. And it's really through that route that I was always interested in emerging infections. So I came to Liverpool about 20 years ago, and we've built up a big infection research portfolio across the whole faculty of the University of Liverpool. I've been, since 2014, the director of the National Institute for Health Research, Health Protection Research Unit in Emerging Infections. It's a bit of a mouthful, that, but effectively the government back in 2014, with some foresight, put some research money into emerging infections, and we won the competition in Liverpool to host that unit. So we were heavily involved in things like Ebola and Zika, and then, of course, COVID-19. And then finally, in 2021, in Liverpool, we launched the Pandemic Institute, which really capitalizes on some of the amazing things that happened in this city during the pandemic.
Fantastic. And who better to start asking these questions to, especially at a time, I think, when COVID-19 has had such a huge societal impact, an impact on industry, an impact on travel, and just the general impact it also has day-to-day on healthcare here in the UK and worldwide. I guess the big question that people always ask us around COVID-19 is, have we really seen the back of it? And I'm always cautious about saying that numbers are coming down, although we don't see as many people around being affected by it or hearing about it on mass media as much. But what are your thoughts on where we are, and what is autumn going to bring?
Well, I should start by saying, I've just come back from the Edinburgh Festival, where I had this family show called COVID for Kids, and at the end of my show, I show some BBC clips from BBC Breakfast, Radio 4, etc. Lots of stuff I did, and I put up this whole list of this whole series of clips where I predicted something and got it completely wrong. So, like you say, it's hard to make predictions. But on the other hand, you're not helping anybody if you just say it's impossible to predict. So I'll give you my best guess, which was similar to what I did make predictions at the end of the show. So I think, clearly, like you said, we've been through this terrible period. The question, there's going to be a question about what happens in the future. I think we're going to continue seeing infections. This virus is here forever now. It's never going to disappear. It will always be here. I think increasingly we will vaccinate, as we're doing this winter, particularly those who are vulnerable. So a bit like flu in that sense, we'll be protecting the vulnerable into the future. Longer term, and here's my prediction, which may prove to be completely wrong, but the COVID-19 virus, SARS coronavirus 2, came out of the blue. And we look for precedents with other coronaviruses. And there is another coronavirus called OC43, which nobody's ever heard of because it's just a cause of coughs and colds in young children. We think possibly that one emerged in the 1890s, and there was a pandemic then. It was called Russian flu. It was called flu not because we identified a flu virus, because we couldn't detect viruses then. It was just called Russian flu because it was a respiratory illness. And there's some suggestion now that actually that Russian flu pandemic in the 1890s was the emergence of this OC43 virus, which of course is around so much now that we all meet it as children. It causes coughs and colds in children. By the time we're adults, we've met it so many times we don't get severe disease. So it may well be, this is my prediction, that SARS coronavirus 2 will infect people so much that actually in years to come, by the time you're our age, you won't have any symptoms because you'll have met it so much as a child. So eventually it may settle down. And you can invite me back for a podcast in 20 years' time to show me that I was completely wrong.
I think that's fascinating.
That's my feeling. But what's your feeling?
Damn.
I mean, are you familiar with OC43?
No, first time hearing about that.
Right.
But I do like the way you've explained it. You have this flu from the 1890s. Well, we didn't know it was a flu, right? And right now it exists and there are no symptoms. However, the flu, the common cold caused by influenza, it still causes us problems even though it's been around for so long. So how does it kind of differentiate between that and...
Yeah, it's a really good question, and it partly relates to the different types of viruses, doesn't it? So influenza viruses, and I'm not an influenza virus expert, we should make that clear. I'm barely a virus expert. I'm happy to talk about some more than others. But we know that influenza viruses, they have this genetic drift, which is a slow change of the viruses, a bit like what coronaviruses do. We've seen the mutations, just small mutations, just a tiny change in the genetic code can make a massive difference. So flu viruses do those small changes. They also do shifts where there's a complete big change. And so flu viruses have an ability to change much more, I think, than coronaviruses. And that's why every season we have to see what's the prevalent type of flu virus and what problems might it cause.
I think that's really interesting, Tom, because I see it from a physicianly perspective as a general internal medicine physician, where I think the challenge with COVID-19 and the various strains has been it's not just the fact that the virus evolves, but actually the fact that along with every step of that evolutionary process, so do the symptoms and the way it affects people evolves. And I think that's been the big challenge with COVID-19 is trying to tell people what to expect as their diagnostic symptom. That's for one. And then the second bit is trying to explain to people why catching COVID causes different things to happen to different people. Back in the day, pre-vaccination, it was always the concern around severe illness, hospitalization, acute respiratory distress, and the need for ventilation and oxygenation to be delivered in a hospital setting. But as we've developed with more and more spread of the infection and vaccination has become better taken up, what we're seeing is that flu-like illness. Yeah. But we're also seeing beyond that. We're still talking about symptoms, if you were to go from head to toe, just simple things like headaches, dizziness. We're talking about loss of sense and smell. We're talking about cough and breathlessness, varying kind of intensities and durations of sore throats and breathlessness and cough. Gastrointestinal dysfunction. So, people who are just not able to settle in terms of certain food intolerances almost that they develop post-COVID. So there's a whole spectrum.
There's a whole range. And also some of the things, I think right at the start, we accepted this was a respiratory disease causing respiratory problems. One of the big surprises and one of the things we picked up on in Liverpool because of our interest in brain infections is the neurological problems with COVID-19, which we weren't really expecting, but it increases the risk of strokes. It can get into the brain and cause seizures. It causes confusion. So this has been one of the big unexpected areas, but one where we've done a lot of the work out of Liverpool here. But I think, like you say, and I think this is one of the challenges for people in getting through the whole pandemic, if you like, that we've gone from a situation where this was a severe disease and people were told to be very wary of it, to now most people are protected through the vaccine or because they've already had infection and they've got some natural immunity. And we're now beginning to tell people, well, we have to start treating this like a normal cough and cold. And some people really struggle with that. And you see that. You see people very anxious to go out, still wearing masks, still very worried about the whole thing, and then others who are completely blasé about it. So it is hard for people because the messages have changed as the pandemic's changed.
It is, and I think when you look even just beyond the individual personal risk, one of the risks that I'm very acutely aware of, and you will be too, is the impact on healthcare delivery in general. I mean, there's a lot of news out in the moment around how the NHS, with the new kind of prime minister in place, is in a place that it has never been before. It's not been like this for decades, is where we are, and it feels like that. And I guess the challenge we find is that although COVID-19 isn't causing people to be as severely ill as it would, if it's picked up by someone who is older, they are limited, they are fatigued, they are unable to perform their day-to-day activities. And one of the things we find is that patients who are in hospital are unable to function and get home because they're just so fatigued and so impacted by that mild illness. And then we still have the restrictions on trying to get people back into their care environments, be looked after in the community. And it's about playing it safe, but that is putting a huge amount of pressure, I think, on the healthcare system as a whole.
Yeah, I mean, the healthcare system has been battered, the whole system. We've seen some pretty unhelpful things. You mentioned our recently appointed Prime Minister. We've seen, I think, some pretty unhelpful discussions during the debate between the two contenders. We had, last week, we had Rishi Sunak talking about how the lockdowns were a disaster. Lockdowns were a disaster, but if we'd not locked down, we'd have had a bigger disaster of hundreds of thousands of deaths. So, it's pretty disingenuous, I think, at this stage to start rewriting history or trying to rewrite history. We had to intervene or we'd have had unacceptable numbers of deaths. And then, of course, Liz Truss, who is now the Prime Minister, is now saying that she's going to cut funding from the NHS to put more into social care. Certainly social care needs support. I'm not sure many within the health service feel that that should be at the expense of the health service. And the other thing that Rishi Sunak said is that the health service has been devastated because of clearly the changes that we made, the lockdowns, diverting all of our healthcare resources to try and stop people dying from this respiratory illness. Yes, it has meant that cancer services were affected and all the other services were affected. And again, Rishi was trying to reinvent, but to try and suggest that things like cancer care and all the other healthcare would have been better off if we'd not done the interventions. I mean, we wouldn't have a health service to be providing any of the care now if we'd just gone for the let it rip policy. I don't know what your thoughts are on whether
absolutely
on those interventions and whether they were the right thing to do or not.
Yeah, I think from my perspective, I think the challenge is that, as physicians and people in healthcare, preservation of life comes first.
Yeah.
And, you then deal with the consequences accordingly. And obviously, without trying to taking this discussion into the political arena, I think it's always a fine balance, and there will always be opinions. But, at the end of the day, what we're here about is healthcare, and keeping people well and keeping people surviving and living longer and healthier lives.
Absolutely. Although, on my Scouse Science podcast, and this is why I'm really keen to do this, because I host my own podcast, the Scouse Science podcast, and on that we had Matt Hancock. And we didn't, we're clinicians, we're researchers, we don't want to get heavily into politics, but I was interested to discuss with him health policy and science policy. And I did get him to finally admit that this phrase, we're following the science, was basically not true. They were advised by the science, meaning listen to it and then decide whether you want to follow it or not, which is fair enough. Those are the decisions politicians have to make.
Absolutely. So I'm going to bring Dami into this, because one of the things that we've obviously been doing is making testing available to people at various levels. So that's not just within healthcare settings, symptomatic, but asymptomatic testing for people in workplace environments, for people traveling, and for people in sport, as an example, especially with contact sports like rugby, for example. I guess we're at a time where we're still doing a lot of testing. The onus isn't so much on testing anymore because we've kind of downgraded it to a flu-like illness, and because people are more protected by virtue of vaccination or prior infection. One of the things that constantly comes up in my conversations is, human nature wants to know what they have as opposed to what they don't have. So if you have flu-like symptoms in the current environment and you do a test for COVID-19, but it's negative, is that good enough? But I think we've gotten to a point now where technology, lateral flow tests are becoming so available to not just cater to COVID-19 testing, but you can test a whole host of things. And obviously, Dami, you're from a technical laboratory-based background and have some insights into this. So talk to us about what sort of tests are available at the moment out there that can give people a more positive response rather than a negative response and say, it's not COVID. What else can we test for?
Okay, yeah. That's a very good question, because as we approach winter, we might see a new upsurge in flu cases. We might also see an upsurge in COVID cases. So there are lateral flow tests, which just test for, let's just call them proteins, on the surface of the virus that we're looking for, and they will give you a result. Now, I remember, it seems like a long time ago now. Is it 2 years ago? When the first lateral flow test came to the UK, and these things were not accurate at all. And I mean, I was looking at results that were 50%. And these tests were done in care home settings with people with significantly high viral loads. But now, we could say the plus side of the pandemic is that certain technologies have been accelerated. So the use of lateral flow tests have now become the norm. I didn't even know what a lateral flow test was until the pandemic, even though the science makes sense. It just wasn't a common term that you would see. So just looking at the different tests now, we've got lateral flow tests for pretty much diabetes now. You've got lateral flow tests to check for heart inflammation. And this technology has just kind of blossomed, I would say, thanks to the amount of funding that was spent on lateral flow testing and even PCR testing during the pandemic. But just going back to what we were talking about earlier about COVID, you said something quite interesting. You said the way COVID affects the brain. And that got me thinking, right? Because in the early days of my COVID work, I was reading a paper, and the biochemistry pathway, so the way COVID affects the body is quite unique. So it instead of going from A to B, just to make it quite straightforward for our listeners, COVID tends to go into C and D and E, and then before you know it, there's something else wrong with the body. So for example, some people are significantly fatigued just by having COVID. Right? And then some people have hearing problems afterwards. Some people have lung problems, kidney problems. And is that something you've seen as well, quite common? So that's just a food for thought right there.
Yeah, I think, first of all, I think you're right that the pandemic has brought certain areas of science along massively. It's a bit like I think people used to say about the wars. Science advances massively during wars. It clearly does the same in pandemics. All the attention is focused. Lots of other work stops. So, some things have really moved forward, haven't they? Lateral flow testing, PCR testing, mRNA vaccines didn't exist. Now everybody's making mRNA vaccines for everything. So some things I think have really leapt forward. In terms of the virus and what it's taught us, many viruses will go into different tissues and cause different problems. But I think, when you have one virus that's it's affected the whole population of the globe multiple times, then the things that would normally be a very rare tip of a small iceberg, are now a bigger tip of a big iceberg. So we're seeing things, we're spotting things that you might not otherwise have noticed, I think. If you've got a rare viral infection that's caused an odd hearing change, well, you're not going to have the test to know what the virus is anyway. The hearing change happened and then it got better. It was a bit of inflammation in the middle ear. But now, because we know everybody's been affected with the same virus in this time window, and we've had the ability to test for it, it means we learn a lot that we wouldn't have otherwise have known.
Absolutely. And I think one of the things that comes out of a lot of the conversations I have is once you test for a virus, which you can do, and you can do it in real time with lateral flow devices and point of care testing, is you then go to the question where a lot of people go to their general practitioner saying, I've got a sore throat, my cough's not going away, I want antibiotics. And actually, the lack of a positive viral result sometimes doesn't allow a general practitioner, although we must try and draw that line in terms of antibiotic prescribing and stewardship, because there is a big issue beyond viruses that we have to deal with in the infectious diseases world, which is antimicrobial resistance or antibiotic resistance. And it's something that, unfortunately, COVID kind of overshadowed, but there was so much momentum building up in that sphere. And I think one of the works or areas of work that the Pandemic Institute has been doing with some of its PhD students has been around antimicrobial resistance. And I don't know what your thoughts are around that, Tom.
I think you're right that we now for the COVID virus we have this ability to test. People can test on their own at home. I think it's going to be an interesting question, or there was a question, once we started pulling back on some of the social restrictions, then you kind of say, well, are people still going to test? What's the point of testing? Do they want to keep testing? And what's not been clear to me is whether, in the hospitals we are still testing staff and anyone with symptoms gets tested, et cetera, et cetera. It's not clear to me whether that will continue forever. And then if we're doing it for a COVID cough, well, why aren't we doing it for a flu cough and for other respiratory viruses? So will we reach the point where people will want to test, when we should be developing tests for every pathogen that we can, so that every cough or cold you can test and determine what the bug is. And as you say, one advantage of that might be you can tell people for sure you don't need antibiotics because actually this is a rhinovirus. It's a virus which is never going to be, the antibiotic's not going to make any difference. So, I think the jury is still out. I think we have to see how that all develops.
And I guess the other flip side to that is vaccination. I mean, you touched upon it, and so obviously mRNA vaccines were unknown, and now they are, and they're used commonly, and they've been successful. The next question that always comes up is we're coming up to a winter where flu and COVID potentially could both be, challenges for us. And the current policy is over 75s and vulnerable patients to be given the COVID-19 booster. I don't know what your thoughts are. I mean, I know there are people out there, and personally, I feel that, if there was a booster offered to me, I would have one. Mm-hmm. And the question is, at what point do we start to offer COVID vaccinations to people? Is it the right thing to do? Should we still be only targeting high-risk populations? And the second bit is, what about flu and COVID vaccines? Do you do them simultaneously? Do you separate them in time? And do you give people the choice?
Yeah.
I don't know what your thoughts are on that.
There's work being done in all those areas. I know in some of so a lot of my work is in lower and middle income countries, poor countries overseas. And there, for example, one of the diseases I work on is called Japanese encephalitis, which is a mosquito-borne virus that gets into the brain. And we've done work over the years on vaccination against that. But then also seeing, can you give that vaccine at the same time as the measles vaccine? There's clearly benefits, and we're all familiar with the MMR, the measles, mumps, rubella vaccine. There clearly are logistical benefits in being able to give multiple vaccines at the same time. But you have to do the work to show that they are not getting in the way of each other in terms of triggering the body's immune responses. So, yeah, but ultimately, I guess, ideally you would have the winter shot that includes everything that you need.
And I guess I'll go back to some of Dami's kind of interests as well. In terms of the Pandemic Institute is obviously doing a lot of early detection of emerging infections. And, in terms of, we were having a discussion previously around how wastewater is tested to look for changing patterns. I think it was the polio outbreak that was
Yeah.
picked up in that way.
Yeah.
And I don't know if you've got
Yeah.
any comments on some of the work that you're seeing or want to be, want general public to be aware of that's going on to plan for.
Well, so the Pandemic Institute has 5 domains, 5 areas of activity, and it's about predicting where future threats might occur, preventing them, preparing so that we're ready for when these emerging infections happen, and then responding to events that happen and then recovering from them. And so we've got activity in all of those domains, and we are ready to respond to emerging infection threats. I've said to people, if we wait for things to become a pandemic, we've already failed in our mission. So our institute is really about tackling emerging infection and future pandemic threats. So if we take something like the monkeypox outbreak, which we've had recently, we were able to very quickly mobilise some funding. We put £500,000 into research across all of those domains for monkeypox research, particularly developing diagnostics, actually, because they are needed. Monkeypox, as you'll know, can be passed from anyone to anyone, but this outbreak seems to be particularly associated with men who have sex with men. Now, those are not always the people who want to be rushing off to a clinic, going into the GP and saying, oh, I think I might have monkeypox. There's stigma attached to some of these diseases, unfortunately. So a test that people can do, a lateral flow test that they can do on their own at home, is a real game changer in terms of controlling that disease. And especially, even if not so much in this country, but in countries where it's against the law to be homosexual. There's stigma in many countries, but if it's actually against the law, then you're going to have a real problem in controlling a disease where that seems to be one of the primary routes of spread. So, I'm proud of the way our institute responded to the monkeypox outbreak, and we've been able to very rapidly support research across several of those domains. Polio is an interesting. So I've seen polio. I've looked after kids with polio from my work in Asia, and the screening that's done, the routine screening that's done in sewage, allowed these polioviruses to be picked up. And you might normally expect a very small number because you will get people who come into the country carrying the virus. But actually what's been happening is the numbers that have been detected are above what you'd expect to suggest that there's some ongoing transmission in places like London, also in New York. So, it's a good example of how screening programs can be really important to pick up. And so, of course, now there's a big push on vaccination against polio in the vulnerable populations, in particular in children in London. But it's a good example of how screening programs prevent problems becoming a...
Absolutely. And I think, it's nice to know, and this is the bit that I think a lot of us are almost oblivious to, is that this surveillance does go on in the background, and it's about health protection, and it's about public health, and it's about that early identification so that we don't deal with that next pandemic and we deal with it early.
So some of the work the Pandemic Institute is doing is in partnership with our overseas collaborators, looking at what problems are emerging there. Ideally you want a heads up to what's coming, and you want to be able to restrict emerging infections before they even spread. So we have collaborators in Asia, in Africa, in Latin America, who we work closely with to try and see what's coming.
Let me ask you a little bit. So you obviously mentioned Japanese bee encephalitis, and that's kind of your specialty areas, isn't it? So vector-borne diseases, i.e. insect-borne,
mosquito-borne,
tick-borne. Yeah. Obviously, global warming is a big issue. Climate change is a big issue. And I think more and more people are seeing the impact it's having on climate change in the physical sense of droughts, impact on water, impact on flash floods in places where they were never there before. But the bit that people don't always pick up on is that change in climate is also changing the way that vectors and insects and ticks and illnesses are spreading too. So what are your thoughts on that?
Yeah, so as you know, I'm the Vice President of the Academy of Medical Sciences, which is a UK organisation. And at COP27, the Academy released a whole policy document on climate change and health. And a couple of months ago, I was in America at a joint meeting of our academy and their National Academy of Medicine looking at climate change and health. And so vector-borne diseases, mosquito-borne diseases, diseases like Japanese encephalitis, dengue that I've been studying all my career, those are spreading, they're increasing in prevalence because in Nepal is a very good example. So in Nepal, this disease, Japanese encephalitis, which is mosquito-borne, has always been in the lower regions where you have the rice paddy fields where the mosquitoes breed. And over the last 20 years, the disease has moved up into the foothills of the Himalayas. Now, previously, those foothills, they were too cold to support the transmission, to support mosquito growth, transmission of the virus. We've had just a small increase in temperature in that time, but enough so that you've now got mosquitoes in these areas and you've got these diseases spreading. And that's just one example. There's similar examples of malaria creeping up mountains in Africa because they're getting warmer. So I think the vector-borne diseases is one very obvious example of climate change and health that I've been studying for the last 20, 25 years. But really the messaging around climate change, I think, has changed in the last couple of years. And, it's been, personally, I think it's not been done brilliantly. I think people have talked about saving the planet. It's not the planet that needs saving. The planet will be here, even if we're all dead and buried. This is really all about intervening to protect human health, okay? So, the kind of changes that we are seeing, even now in the UK over this summer, the extreme temperatures, those temperatures kill old people. It's as straightforward as that. Impacts again on, we're seeing flooding. Flooding contributes to waterborne diseases. So we've seen it in recent weeks in places like Pakistan. Masses of flooding, which you don't just have impacts from people drowning, but you get spread of waterborne diseases. So all of these things are coming. And but on the positive side, some of the changes that are needed also have positive impacts on health. So if we reduce our use of fossil fuels by driving to work less often, cycling to work, walking to work, getting the bus, all of these things reduce the pollution, and they contribute to positive health. You're a general physician, I think. So, we know now that when there's lots of pollution, you see kids are getting asthma. Older people are coming into hospital with respiratory airways disease. So a lot of the changes that we need to make are things which will actually positively impact on our health. So I came away, you can see I'm almost evangelical about it. I came away from this meeting in America with a much better understanding of what the issues are, but about how we can tackle them to actually in a positive way.
It's fascinating, Tom, to hear your perspective on this stuff. I think, the impacts of climate change go well beyond what we would traditionally think of. And I guess all of us has a personal responsibility, both for the climate as well as looking after our own health indirectly by making those changes that you've suggested. I think the other bit that always, interests me about your journey so far, which has been, decorated by all means, I think, is your communication sort of style. And obviously, as fellow podcasters, what do you see as the future for us as healthcare professionals trying to get across credible, relevant information to the public? Because I think, there's a lot of stuff that you can pick up on TikTok and YouTube, which doesn't necessarily muster what you need in terms of quality control. What are your thoughts on communication?
I think there's been, certainly in my career, in my lifetime, there have been really interesting changes. So when I trained, which was, some hundreds of years ago, and I don't know about when you trained, but basically, you were kind of told, keep away from the media, don't go anywhere near these people, it's going to spell trouble, you just quietly want to do your job, do your research if you're a researcher, do your job as a doctor. And, that's kind of what we were taught. And that's completely turned on its head during my career. So, we are now encouraged to engage with the media and to get our messages across. And I think for various reasons. Firstly, if you are a scientist, like I am, a lot of my research is funded by the UK taxpayer. So I should be, out there talking to the taxpayer about what I'm doing. Why not? They're paying for it, So I think that's an important aspect of it. I think another important aspect is around communicating to the public and to policymakers. So one of my earliest pieces of research in Vietnam decades ago was on Japanese encephalitis. And interestingly, it was on how it caused an illness that looked just like polio, with the other disease you mentioned. And this was published in The Lancet, so quite a good journal. And the message was that people who looked like they had polio, actually some of them had this completely different virus, Japanese encephalitis. And I thought this is quite an important message for policymakers. If you are trying to eradicate polio, and there's another disease that looks just like it, you need to know about it. So I kind of, in my naive way, published my paper and thought, well, it can only be a week or two until the World Health Organization are on the phone to me saying, Tom, please come to Geneva and tell us all about this really important work. But it doesn't work like that. You have to engage with policymakers. If you think you've got something important to say and you've done some important work, you have to engage with the public, engage with policymakers, and be ready to talk to them about it. So all of that, if you like, predates the pandemic. That's just a shift in thinking. But then additionally, what we've seen, especially during the pandemic, is that, there's a lot of nonsense that's talked. Some of it just by people who are well-meaning but ill-informed, and some of it by people who are malicious. And, we have to, we can't sit back and just allow all of those messages to be out there without conveying some sensible messages. And so, that's where podcasts like yours are important, like our Scouse Science podcast are important. Also, I think increasingly people want to know, the public, one thing that's been really interesting in the pandemic is how much the public do want to know about science. They do want to understand things. And we have to capitalise that and make sure that we're presenting it in a way that people can understand. So, I think podcasts are important. As you may know, I wrote a book a few years ago called Roald Dahl's Marvellous Medicine, which was a completely different thing. But again, it was popular science. My show in Edinburgh, which was for families. I think we have to take all the opportunities that we can. I would say we've been discussing some of this at the academy. I think you don't want to get into spats on Twitter. It's not helpful. And there will be people who, I know you have a good following for this podcast, and there'll be people who will be attacking it and putting rubbish out there. We had a meeting of our Pandemic Institute a couple of months ago, where we had, it was quite a high-level meeting with some senior people from London, politicians coming, etc. And then following it, there was the usual kind of on Twitter, people slagging us off, saying, why, how are you in a room with no windows? Why weren't you wearing masks? Blah, blah, blah. Well, of course, there's no government incentive. We're not meant to be wearing masks necessarily. We don't have to do everything windows. But I said to the team who were upset by it, I said, don't worry, don't respond on Twitter. You never respond, because all it does is gives fuel to it. And also, if you look at the Twitter feeds, other people responded and said, well, what are you talking about? There's no mandate to wear masks now. But I did say to them, look, all this extra tweeting, this is great publicity. Just sit back and enjoy it and don't worry. But I think in general, the message is don't engage, but instead put out the positive messages that we want to do. And that's why it's so great what you're doing here.
Fantastic. Dami, I was just going to pick your brains on, from a technical world point of view, what are the kind of outlets that people have, and how's information kind of received and dealt with?
Just going back to what Tom said about misinformation, I remember when COVID came out and there was this old 5G thing. I don't know if you remember that.
Yeah, I do.
Yeah. And I actually looked into it. I looked into it just because I'm curious.
Yeah.
What's actually going on? And one thing I noticed was during that time, a lot of people believed that. A lot of people genuinely believed radio waves can cause a viral infection. And I found myself in a situation where I had to actually post on Instagram that radio waves don't cause viral infections. Please stop believing this stuff. And I think a lot of social media outlets were they started putting all this kind of filters to remove the false information. Now, one thing I do like is that over time, I've noticed that people are more informed than they've ever been. If you go on social media now, a lot of that misinformation, people kind of quickly debunk it before it becomes something else.
Do you see that then?
Yeah. I mean, the internet is now a wealth of information where even doctors are on TikTok now.
Yeah.
You know, doctors are on Instagram educating people about, I mean, there was one I randomly saw about things that I would have thought would have been a sign of people not being hygienic, but it turns out the way it was explained by a physician, it's normal. And a lot of that is becoming more accessible to the average person. And even podcasts like this, people are listening to things. And I think forget about the technology, just the way we live, people are more concerned about their health, I think, because of the pandemic. I think since COVID came, a lot of people just had time to watch videos on YouTube, you know, just listen to stuff and just go, what's actually going on? And I think that's really changed the way people approach spontaneous information. Oh, 5G causes COVID. They will go on the internet and just do some research.
I mean, the worry is, you know, that when you do, you know, there is so much of this kind of rubbish out there, the 5G causes COVID stuff. And, you know, I mean, it's interesting. So you did engage. I'm still not, I mean, officially we're told don't engage, you know, don't get into the spats. But I don't know, I've got a friend who does a lot of engaging. And, you know, you have to be prepared for lots of rude stuff and not, you know, be ready for that and not get upset by it. I personally, I'm just not sure. But how did you find it when you know?
Interestingly, someone actually engaged with me.
Yeah.
And in a very borderline controversial way. It was like, no, you don't know what's going on. You haven't read all this new stuff. And I go, okay, I've been a scientist for so long. And as your friend, and it's actually a friend.
Yeah.
I can tell you, it doesn't work like this because physics doesn't just transform into a biological, you know, entity. You know, you can't just have that. And I kind of broke it down and said, look, there is no agenda. This virus is formed, just like the flu formed many thousands of years ago and is evolved over time. This is a new virus that's just spontaneously formed and has become very infectious. Yeah. You know, we have to deal with it. And eventually people would have antibodies to hopefully live with it. And I think I checked today on the ONS stats, I think 95% of everyone has like antibodies to COVID. So it's like, and now in hindsight, it looks at that conversation and goes, it was right.
I mean, it's great that you did, you know, but I know people where family members have just, you know, this family's visiting that family. They know that these guys have not been vaccinated and won't be vaccinated. And they kind of have to agree that they're just not going to discuss it because it'll just end up in a big family row.
So on that very controversial note, I'm going to bring it back to just looking forward to the future for you and for your group who are involved in active research. So tell us where the frontier is going with your research group and what are you working on that we should be aware of or people can look forward to?
Well, so I mean, there's different things. You know, the Pandemic Institute is we have our first anniversary coming up. I was going to say tomorrow, but I know this isn't a live podcast. But anyway, people will be able to look back at the first anniversary. And we've responded quickly to things like monkeypox. We're now we're about to put out a grant call for looking at the recovery end of our overall program, because I think that's really interesting, how we work with people like insurers, how we, for future threats, how we, come the next major threat, can we keep things going without such massive lockdowns? Can we work? It's questions like, the lockdown was a very crude tool, okay, but we want to answer questions like, well, actually, should you be closing pubs or closing schools? If you just stop people getting on the buses, would that be the right thing to do? So because if you think about it, a lot of that happened without much previous research to tell you what to do. It was all intuitive. So there's opportunities around that. Within my own research area of brain infections, we are very interested in So I talked about Japanese encephalitis, and that is inflammation and swelling of the brain caused by this virus called Japanese encephalitis virus. But there's the same condition, brain inflammation, can be caused by COVID, but we also see it with lots of other viruses, and we also see patients who have it, and we don't know what the virus is that caused it. So we're having a fresh look at this whole issue of brain infections, using some of the things we've learned during the COVID pandemic. We also have some new treatment trials. We've just started a new treatment trial of encephalitis. So that's kind of my own personal area. But then also through the Pandemic Institute, we're doing much other stuff. And I'm sure I'll be in terrible trouble because there's all sorts of things I haven't mentioned. But, those are the ones that immediately come to mind.
Fantastic. And I think on that note, I'm just going to take the opportunity to say thank you so much for spending the time to speak to us today, Tom. Obviously, you have a long career still ahead of you, so I'm not going to say after your illustrious career so far, but it has been. And I think the CBE accolade, which was bestowed upon you, is more than well deserved. And I think it's been a revelation hearing your insights into infectious diseases, the pandemic, but more than that, it's really been interesting to see, the ways in which you've engaged with the public. The Edinburgh Fringe, the book. I have to go out and now read it, although I have been exposed to it. I'm going to go back and read it in more detail, because I think we all, as healthcare professionals, trying to spread the word, trying to spread that information for the public, need to find those avenues and those ways to make it credible, accessible, in plain speak, so that people can take those messages away. So I'd just like to say a big thank you to you, Tom, for being with us today. I hope you enjoyed it as much as I did.
I have, and also just to congratulate you guys on the work that Dam Health have done. I mean, you talked about the diagnostics earlier and the various ways you've used it. That was from nothing. You've built something incredible. And my first contact with Dam Health, I should say, was just going along and getting a test. Because and for so many people, it's been a really important and needed resource. So I wish the company all the best for the future.
Thank you very much.